I've decided to expand on the talk we did on Thursday's Zoom session, where you were asking questions about the history from the patient, and I have to select out areas that would give you some concerns. Okay, so I've got a reach point that's relevant. I've also put a diagram to try and simplify the thing for you, so I hope this helps. First, a diagram I gave you on sorting your way through the examination of the cervical spine, particularly the craniovertebral region. As I said, it's contextual. There is no routine exam for your patients. You have to take the context from the history. If it's trauma, you do a completely different exam than if it's a routine biomechanical dysfunctions history. Totally different. So forget the idea of a routine exam. They are specific to the patient's history. In this case, this is an exam for trauma or somebody with particularly serious symptoms or potentially serious symptoms. So, first off, what I've done is I've really simplified this. Horizontally going across the top, there are other things you need to be careful of, and below them are the presentations that would indicate one of these conditions. I'm not going to go through those indications. We went through them on Thursday and it will only clutter up things. So I'm going to leave this really simple. If you believe there's a serious fracture or dislocation, do not touch their neck. All right, don't move their neck. You can do a neurological exam, but my suggestion is you put them in a hard collar, as hard as collar as you can find, and then do the exam. Preferably, when you start to suspect this, get them to the emergency room. Are there central or neurological symptoms or even signs? This would be frank myelopathic signs or non-segmental signs. And these may be atypical presentations of cold injury, or they may be plexopathy. But even plexopathies are well beyond your usual experience, and these can be traumatic avulsions, they can be tumours and so on. So all of these should be considered serious neurological symptoms. If there's none of that, is there a potential for a cervical vertebral injury, artery injury? So you know all these, we've been over them over and over again. If not, then move to a physical exam. Now, if this is post-trauma, or you have a headache patient or a dizzy patient that you've got particular concerns about, I would suggest you do a neurological exam first. So do cranial nerve, spinal cord, and other neurological testings. Then you can move on to non-movement stress tests of the neck to see if you can reproduce those symptoms. And if you can, it makes you a bit happier about those symptoms. Progressive minimized decline if you're happy there's not a vertebral artery problem and you're just making sure. A sharp Purser test, maybe a ligament test, although it's not as important. And then you can move to the musculoskeletal diagnosis and then the biomechanical diagnosis. This is contextual though, okay? I can't say that enough. It's contextual, so you save it for when the context says you need to work this way. This is our first case, 56-year-old man complaining of left paravertebral upper pain, gradual onset of the last 2 weeks, all the things we talked about here yesterday. So the points I would be concerned about here is the fact that the pain is upper lumbar, not thoracolumbar, but upper lumbar. The reason you worry about this is because this is a site for metastases, bony metastases, the upper lumbar spine. Disc herniations are extremely rare here. And biomechanical dysfunctions are not terribly common anyway. You don't have to be paranoid about this, but this should stay in the back of your mind all the time, is that this may be more serious than you think it is. The gradual onset over the last 2 weeks would suggest it's not a biomechanical dysfunction, but there's nothing unusual in that. No obvious cause of a trigger, again, sort of saying this is not likely to be a biomechanical dysfunction, but again, that's not unusual. The fact that he thinks it might be a new bed he bought earlier may or may not have anything to do with it, keep in the back of your mind. This is the interesting one. It complains of pain on prolonged walking uphill and fast walking. Now, musculoskeletal, these fast walking is an extension activity. Walking uphill is a flexion activity. So we've got a dichotomy there. Walking uphill is a flexion problem, walking downhill is an extension problem, and they are both present. So this could suggest this isn't a musculoskeletal problem. Schober's test is positive. I'll change the spelling on Schober's to make it right. That could help confirm he's got severe central stenosis, and his range of motion lost in extension backs that up. There's no pain on passive overpressure. PAs are stiff all the way through the spine and tender only over L5. So while he may well have central stenosis, this wouldn't seem to be the source of problems for the upper lumbar pain. If it was around L5, then very likely, but it's not, it's higher up. So these are the things that sort of stand out for me and says you need to rethink this. This isn't a common problem. Here's our first diagram. So based on 1, 3, 4, 6 and 7, stenosis might seem to be a reasonable hypothesis. However, there are a number of reasons we've found that it's unlikely to be. Well, there's a lot against it being that. So the way I would go about this then is a negative differential diagnosis. So the main musculoskeletal problem I'd be concerned about with a man of this age and his symptoms being an exertional response to the pain responses to exertion, I would be thinking of aortic aneurysm. Then lateral stenosis, biomechanical dysfunction, and a tumour. So we can palpate the aorta. If that's negative, you can't really get rid of the idea of this being aortic aneurysm, but it's unlikely if you can't feel it. If you've got a very stout, obese person, then you may not be able to feel it. It's probably worthwhile, if you can't find anything else, to send it back to the doctors querying that. Lateral stenosis, you want local stiffness. The reason I don't think this one is lateral stenosis is because PAs over L1 and L2 weren't painful. So if they're not painful, they're not producing pain in the spine, almost certainly. If you find a biomechanical dysfunction, then you can try and manipulate it. If you don't find one, then that tends to rule out biomechanical dysfunctions, if you're at all any good at doing a biomechanical examination. And then for a tumour, pretty much all of your tests are going to be negative, except maybe for PAs. And given that the PAs are negative, it's unlikely to be a tumour, but you found nothing else, really. So I would send that back to the physician, at the minimum saying, I really don't know what this is. This is a 14-year-old boy playing soccer, got kicked below the left knee and medial. Now, there's medial palpation tenderness, and that's about it. There isn't anything else. He's got no pain on function, no pain on your test movements, just tenderness in that area. So the parts that would bother me about this is it's been 3 weeks since the kick and there's been no change, and there's no pain on active, massive or passive movement or ligament stress tests. That is what would concern me mostly in this history. On the surface, this looks to be either a periosteal bruising, Pezan-Sorinis tendinitis, or a Pezan-Sorinis tendinopathy. But the issues are number 3 and number 5. That is, there's no improvement in it, and none of your testing was positive. So it probably still is that. It probably is still periosteal bruises. If it was a tendinitis or a tendinopathy or a tendon or a bursitis, you would expect activity to bother it, but you're not seeing that at all. So let's try a differential diagnosis and see where we go to. So one is a fracture. There was a kick and fracture, but the X-ray was negative. Tendinopathy, bursitis, or a tumour. So the X-ray was negative, so while that doesn't rule out the fracture, it sort of says, okay, go somewhere else for the moment. If this is a tendinopathy, you would expect isometric knee flexion via the cerebrovascular to be positive, and you would also expect that to be tender. Now the insertion may be, and that's maybe what is tender about it, but all of the test movements were negative. Also, the tendon is between these three tendons. It interposes itself, so you'd expect some compression of this tendon with isometric testing. You don't palpate any tenderness, and again, it's not improving, so you'd expect the tendinopathy to improve over 3 weeks, especially if he's resting it. And he's not, he's fully functional, but it's not getting worse with activity, it's not getting better. So it's probably not one of those at all. So all testing negative apart from palpation. You have to have a tumour going through your mind. Now, as I said, this is what it turned out to be. It was an osteosarcoma. The kick actually fractured the bone. It did show up on the X-ray when they went back to it after the CT scan. I really don't know that I would pick this up though. But there is a couple of incongruities if you really sit down and think about it. The problem is, it is so superficially, obviously, either one of those three things that you may not think about this in any detail. You'd have to catch this when it wasn't improving with your treatment. That's about probably the only way you can do it. This therapist picked it up very nicely though, and I know the therapist well. She's a much better listener than I am, so I'm going to put it down to that. But honestly, I doubt whether I ought to pick this up. Right, the placement of this pain screams sacroiliac joint. There's no real pain in the lumbar spine, it's all in the pelvis area. Now, that doesn't mean to say it can't be referred from the spine, but on first look, this is sacroiliac. Given that, we've got a problem with a 50-year-old woman getting a biomechanical dysfunction in the SI joint. It does happen, but not very often. If this matches up with no previous history, then you really start thinking about other things. However, the next thing is there's severe pain. I mean, this is severe pain on the left cervical in the upper half of the buttock. While biomechanical dysfunctions can cause a lot of pain at the SI joint, probably because the SI joint is a large joint with lots of nociceptors. When it's this severe, it's unlikely to be the biomechanical dysfunction. There's no history of similar pain, which is what you would want with a biomechanical dysfunction, ideally. Objective and subjective findings are positive. The subjective finding is very, very positive. It's extremely tender in that sulcus. It wakes her up at night, she turns over, and now she sleeps on a mattress on the floor. This is a hallmark of inflammation of a sacroiliitis. She has an antalgic limp, which means she has an obligate functional loss, and the anterior gapping test is positive, very positive. So all of this is screaming biomechanical, not biomechanical dysfunction, but inflammation, a sacroiliitis. Now, this may be a sacroiliitis because there's an unstable joint that's become microtraumatically inflamed, but more likely, and what you have to be careful of, is that this is because of a systemic condition. Based on numbers 1 through 6, that is all of them, it's a sacroiliitis. This is the illness script for a sacroiliitis, really. So there's no problems with making that diagnosis. If it is a sacroiliitis and it's systemic, it's probably a reactive arthritis, so you want to be looking for other possible symptoms, other joints involved, gut problems, iritis, enthesitis, and so on. Is it a systemic condition? The differential diagnosis, apart from sacroiliitis, will be a biomechanical dysfunction, visceral referral, and lumbar referral, with lumbar referral being above visceral. The essential illness script for SI dysfunction is not present. This is way too acute, and there's obligate impairment and everything else. The negative, if for a visceral referral, negative findings, and positive PA for lumbar referral, and no findings for referral and/or visceral pain. So everything about this is screaming sacroiliitis. However, having advised her to go see her doctor, get some blood tests done or something, she went to a chiropractor and manipulated and got it better immediately. So this is a very, very atypical biomechanical dysfunction, but my decision was still the right one. This was typically going to be a sacroiliitis. If it had been and it manipulated that, it wouldn't have done any real damage, I don't believe, but it's going to create an awful lot of problems for her for probably days or weeks following the manipulation. So I would do the same thing again. There is really, even if I found a biomechanical dysfunction in there, I would still do the same thing. Refer her back to a physician for him to look at. I don't see that as a failure, to be honest with you. This one was supposed to be post-trauma, I didn't put it on there. But we'll say it's a rear end collision. We have a 35-year-old woman complaining of pain on the right anterior lateral and posterior suboccipital region of the neck. This is both on the right side. Range of motion loss was left rotation extension limited and painful anterior and pain anteriorly, and right rotation extension loss with pain posteriorly. Negative X-ray, history of similar pain over the last 2 years, but not of the anterior pain. So the thing that bothers me about this is the anterolateral pain. Now this could be a torn sternomastoid, or it could actually be damage to the carotid artery. I'm going to ignore the posterior pain, concentrate on the anterior pain because that's what's unusual and more worrying. So H1 based on the location of the pain, torn sternomastoid. Differential diagnosis, sternomastoid tear, carotid artery tear. Palpate for tenderness in the sternomastoid. So pinch it, don't press back into it because you're going to be pushing onto the carotid, but pinch a muscle in a way of palpating. If that's negative, you don't have a sternomastoid tear. So you want to be looking for other signs of this, Horner's, temporal headache, or other signs. If the sternomastoid tear is tenderness is present, but you still got Horner's sign and so on, temporal headache. If not, if it's just negative tenderness in the sternomastoid, treat that as if the artery is torn. Again, this comes down to selecting the worst possible outcome, okay, and saying this is what it is and sending it off to a physician, let him sort it through it. Okay, so 30-year-old man complaining of pain right medial groin, sudden onset while lifting dead weights 2 weeks earlier. He's done no deadlift lifting since then, the pain's been too severe for it. The inflection quadrant was positive when you tested it. Otherwise, the quadrants, the hip quadrants, had full range, no other pain than the inflection. Isometric hip flexion was moderately positive, but, and this is the one that concerns me most, palpation of the hip flexion was negative because everything was pointing to a tear of the hip flexor. But that negative palpation says that is not what it is. Okay, based on everything except for the last item, you would think this was an iliopsoas tear or a tendinopathy. The issue is number 8. That's the one that worries me. So H1 fails. Clearly, if the tendon's not tender, then you don't have a tendinopathy. So if we look at differentials now, we've got an adductor tear or tendinopathy, pubic stress test, pubic stress fracture rather, inguinal hernia, psoas bursitis, or referred. So for the adductor tear, we can palpate the tendons. We can do adduction as well, but palpating tendons where it's negative tends to rule that out. Pubic stress test, tear, it's a wrong history. These things are slower. They come on gradual. So again, though, you can palpate the ramus and see if that's tender. Inguinal hernia, you're going to have to palpate with coughing. That should be negative. But now you're in trouble because you don't do this very often. You may never have actually done it at all. So with a small one, that may not show, you may not be sensitive enough to pick that up. And I've had exactly this situation come up. I couldn't feel it. So what I did was, there was a lot of other stuff not going on that should be going on. So I said to the patient, I want to send you back to the doctor. He does this much more often than I do. I have no idea what really I'm feeling. And the physician said that he had trouble feeling as well, but it was just about there when he really looked for it. If we're looking at a psoas bursitis, first off, it's not likely to be that because this was a sudden onset. You don't get inflammation coming on that quickly. But given that, we can stretch the hip flexors, bring the leg into extension, and then resist it from there. And now bowstring the tendon down onto the bursa. That should be negative. If everything's negative, then it's referred. However, I take you back to what I said about palpating for an inguinal hernia. It may just be that you're not sensitive enough to pick that up. You haven't got enough experience to pick that up. So what I would do then is, if everything was negative and I'm still thinking it could be an inguinal hernia, is I'll do PAs all over the spine, into the SI joint. I'd palpate as much of the lower abdomen as I could. And if all that was negative, I think it's got to be a visceral issue, such as an inguinal hernia.